times. So let me begin to say something about the Russian invasion of the Ukraine. Well, GLO is a non-partisan academic organization trusting in international exchange and collaborations. And violence and war have no place in a civilized world. We are all shocked and deeply moved about what is happening in the Ukraine. An aggression invasion attempts to destroy freedom and independence for the Ukrainian people. Russia is isolated in the world and needs to stop this war right now. Well, we can, of course, do not much, at least not from this group of people here. Let us take, nevertheless, a moment of silence to express our strongest solidarity. Our thoughts are with the Ukrainian people. Okay, thank you all. Let's go ahead. Thanks, Ira and Madloop and Maria for being here, and we're looking forward to an interesting exchange. Thanks.
Okay, I'm happy to introduce today my colleague, Maria Rosales-Rueda. Sorry, you only have Rosales on your name. Who will talk. We usually do keep to the 9 o'clock ending. Clarificatory questions can come up during the seminar. Please keep these very short and to the point. And when at the end, if you finish up 15 minutes ago, we'll have 15 minutes of discussion. Okay. So thank you. It's all yours.
Yeah, thank you so much, Klaus, for your remarks, and Ira for the introduction. And thank you for inviting me to present. So today I'm going to present about the delivery of primary healthcare services and birth outcomes, evidence from the rollout of community health centers. So this is joint work with Ezra Coase and Shivano Kiv. And yeah, also feel free to unmute if you wanna ask any questions. I will try to finish early, but also if it's easier to ask questions on the go, I am happy to answer any questions. So just unmute. So as a motivation, health disparities across socioeconomic status groups are an important concern, and one important key market of health is health at birth. And here in this picture, we show the incidence of low birth weight between pregnant women with less than a high school degree here in black, and pregnant women with more than a high school degree in blue. So these gaps are here in the US using the viral statistics, and these gaps persist today. And policymakers and researchers, and we care about health at birth because there is a significant amount of evidence that have documented that health at birth is an important determinant of future human capital, economic self-sufficiency, mental health, and adult well-being in general. So there has been several policies that have been created and implemented to address these gaps in health. So on one hand, we have demand-side policies like nutrition interventions, for example, in the US as food stamps and the Women and Infant and Children Nutrition Intervention Week. Also, a popular demand-side intervention is expansions in health insurance, like Medicaid for the low SCS families here in the US. And on the supply side, there are several policies that deliver primary healthcare services directly. And an example of that policy is the community health centers program here in the US. So,
Maria, I have a question for you. Sorry
course.
to interrupt you. When you
No,
say
please.
low birth rate, what do you mean by low birth rate? Do you have some number? Like, how do you decide?
So low birth weight is defined in the medical literature as having a birth weight less than 2,500 grams.
Okay.
That's
okay,
the definition. We are using the formal definition of low birth weight. Yeah, thanks for that.
Okay, good. Thank you.
Yeah. So, and that's what, and yeah, that low birth weight is a determinant of later in childhood outcomes and future adult outcomes.
Okay,
so yeah, going back to this idea that several policies have been implemented to tackle those gaps. In terms of causal evidence, there is a significant amount of evidence that have examined the impacts of demand-side policies, but there is still little evidence about, and especially causal evidence about, the health effects of directly delivering primary healthcare services at scale. So in this paper, we aim to address whether access to community health centers improve birth outcomes, and if so, what are the potential mechanisms that can explain these effects.
0.2.
So to be able to tackle this question and to give some causal answer, we are going to use a difference in difference approach and an event study framework that is going to exploit variation both geographically and over time in the rollout or introduction of community health centers across counties and across years between 1969 and 1988. We are building upon previous work by Martha Bailey and Andrew Goodman-Bacon that I will reference before. And we do find evidence that exposure to these community health centers that directly deliver primary healthcare services increase birth weight, decrease the likelihood of being born with low birth weight, and improve other health outcomes at birth, and we will speak about potential mechanisms that can explain these effects. So in terms of the contribution of this project, we provide new evidence about the impacts of this direct delivery of services at scale. And this is very relevant because these community-oriented programs, these community health centers, are now becoming a relevant policy in developing countries in Asia and Africa. So learning from the US experience back in the 70s and 80s can inform these policies in other countries as well. So we also expand the rollout data previously collected by Martha Bailey and Andrew Goodman-Bacon, and we will explain later that we are using some of these new difference in difference methodologies. So the outline of the talk is very standard. First, I will start by giving some background about this policy. Then we go to the data, empirical strategy, the main results on our main outcomes. We will speak about potential mechanisms. We did several robustness checks, and then lastly, we will conclude. So the community health center program was part of the 1965 War on Poverty programs here in the US. The War on Poverty was a flagship program by President Johnson. And as part of this War on Poverty programs, there were some federal grants that were allocated to local agencies to fund the development of community health centers. The main goal of these centers was to improve or increase access to healthcare in economically disadvantaged location areas by locating these sliding scale clinics in those disadvantaged locations. So by locating these clinics in these underserved areas, these centers decrease not only the monetary cost, but also the hassle cost of access to primary healthcare, making it for families easier and less expensive. So let me just briefly mention some of the services that were provided by these centers. So these centers, as I have been mentioning, offer primary health services as well as preventive services. And one of the main services are prenatal and postpartum care. So that's why there is a clear potential link between exposure to these centers and birth outcomes. They also offer voluntary family services, as well as outreach and community and health education. They have in-house pharmacies, and when cases are a little bit more complex, they make referrals to the local hospitals. So the initial phase that introduced community health centers in the late 60s and early 70s funded community health centers mainly in urban areas with high concentration of poverty. And in 1975, when the Congress formalized the community health centers program, this introduction, this rollout shifted towards areas that were more rural and agencies required to serve medically underserved areas. So the community health centers are actually still alive today. In fact, the Affordable Care Act by President Obama provided around $11 billion to expand and bolster the CHC over the next 5 years. Even during COVID, there were funding expansions to community health centers. And nowadays, these centers serve around 30 million people. So let me here just briefly tell you a little bit about who are the users of these community health centers back when they were introduced in the 70s and 80s. Examining some of the reports, we see that 60% of the users had income levels below the poverty line. 70% of the users are racial or ethnic minorities. 50% are uninsured. The largest group of users are children under the age of 14, and then the second largest group are women in childbearing ages. Some of these women can be pregnant women. So now here, I want to provide some evidence about the pregnant women use of community health center services, particularly about prenatal care. So as we saw in the previous slide, around 30% of the users are women in childbearing ages, and around 85% of community health centers provided prenatal care, serving over 200,000 pregnant women every year by 88. So to illustrate more about the sources of prenatal care, we look at one of the few data sources back in the 70s and 80s at the national level that corresponds to the National Survey of Family Growth. That survey is nationally representative, and it was collected in 4 waves in 73, 76, 82, and 88. And here we look at the data to examine what are the sources of prenatal care. As expected, the majority of women, 85% to 90%, use private practitioners and hospitals as source of prenatal care. But for the rest, like for around 5 to 15%, of women, clinics are an important source of access to prenatal care. And here in this graph, we focus on the group of women who use clinics. So in 1973 and 1976, the survey didn't disaggregate the sources of the clinics, but in 82 and 88, they are a little bit more disaggregated. So here the main takeaway is that in 1973 and 1976, around 5% of pregnant women use clinics as a source of prenatal care, and that fraction increased to around 13% in 82 and 88, where here in blue, community health centers are an important type of clinics being used by these women back in the 70s and 80s. And this increase in the use of community health centers coincides, and you're going to see later on, to the largest expansions in the rollout that occurred in 1978 and 1980. So now let me briefly summarize the community health centers literature. So there is a significant literature in the medical and health services discipline that have documented that the community health centers have improved access to healthcare, reduced visits to emergency department, and reduced preventable hospital admissions. And in economics, the seminal paper that have examined the causal effects of the community health center programs is this paper by Martha Bailey and Andrew Goodman Bacon, where they compile this rollout data of community health centers across counties and years to examine the effects on adult health. And they do find evidence that exposure to community health centers decrease adult mortality. So they mainly focus on adult mortality, and in our paper, we focus on the other spectrum, on infant health. Precisely regarding the effects of community health centers on birth outcomes and infant health, there has been some studies that have examined this question, but the majority of evidence suffer from potential endogeneity issues. So in this paper, we try to provide new evidence, new causal evidence about the effects of community health centers on birth outcomes. So before we move to the data, empirical strategy, and result, here I wanted to provide a conceptual framework about the determinants of health at birth to understand what could be the potential role of community health centers. So many studies in economics and in other disciplines have shown that health at birth is determined by maternal and individual characteristics, as well as by social factors. And several of these factors that determine health birth are actually malleable. So regarding the maternal characteristics that influence health at birth, there is evidence that race, ethnicity, education, age, poverty, and genetics determine health at birth. And in terms of social or proximate factors, there is evidence that use and timing of prenatal care, nutrition, maternal lifestyle, meaning stress, risky behaviors, as well as incidence of infectious diseases, and environmental factors like pollution affect health at birth. So, and here I wanted to illustrate that given the nature of this policy, the community health centers, we could expect, because they were delivering primary health services, including prenatal care, we could expect community health centers to influence health at birth through improving access to prenatal care, because during the prenatal care visits, practitioners and doctors give counseling about nutrition and maternal healthy behaviors, we could expect that the CHCs could also improve health at birth by changing these risky behaviors. Also, because they provide primary services, they could affect the incidence of infectious diseases and illnesses during pregnancy. It's very unlikely that they affect factors like pollution and so on. So yeah, any questions before we move forward to the data and empirical strategy? Okay, so let me.
So sorry, Maria, I had one question
Please.
that I couldn't. So when you look at the CHCs, most of the medical staff are the physicians, are the midwives, who provides the kind of healthcare? So
yeah, what we have been able to learn from reports is that I think it's a combination of doctors, midwives, I think as well. So it's trained physicians. It's trained, it's doctors. Yeah, they have primary care doctors with doctor's degrees, nurses, and I think midwives as well. But we could add more details about that. Yeah.
Okay.
Thank you. That's a good point. Thank you. Yeah. So now let me tell you a little bit about the data we are using. So we are using microdata from the vital statistics. That data with county identifiers is publicly available from 68 to 88. That's why this is the period of our analysis, because we need the county identifiers to be able to allocate exposure to our policy. So, and we merge that viral statistics data with the rollout, with the introduction of these centers across counties over time. The main data set, the main source of data for this rollout comes from Martha Bailey and Andrew Goodman-Bacon seminal paper that I mentioned before, where they compile this rollout from different sources. And we expanded their rollout up to 88 using data from the Federal Assistance Award data system. And we also merge or combine data about state and county level control covariates, like other social policies, cash transfers, because they may correlate with the rollout of the community health centers. And we are going to explicitly explore this in a second. So here in this figure, we illustrate the time variation we are exploring. So here on blue, we have the flow of the rollout, meaning we have the number of counties that introduce community health centers in a given year. And in black, we have the cumulative number of counties with a CHC. And we see a significant expansion in the late 70s. By 1980, there were 622 counties with a community health centers. And by 1988, we have 733 counties. So this is basically the time variation. And now here in this map, we illustrate the geographic variation. So from yellow to dark blue, we have the counties that introduced the community health centers early, meaning in 1965 in yellow, then in green in the 70s, and in blue, the counties that introduced community health centers in the 80s. By 1988, as I was mentioned before, 733 counties had a community health centers, and the ones in white are counties without a CHC by 88. But keep in mind that our data goes until 88. We could expand the rollout even more, but we don't have vital statistics data with the county identifiers beyond 88. But here an important takeaway is that there is a lot of geographic variation across regions. So meaning the North and the South and East and West, they didn't introduce CHCs all at the same time. So we can exploit this geographic variation. And even in the robustness checks, we can exploit within a state variation, because in a given state, not all the counties introduce CHCs. So in our robustness checks, we will exploit state by year fixed effects. So now let me here present our empirical strategy. So as I was mentioning before, we are combining the time and geographic variation in the rollout of community health centers. And we use a difference in difference approach. In the paper, we estimate the static difference in difference, as well as a dynamic and event study model. That is the one depicted here in the slide. This is the equation of the dynamic model. So, and just before explaining the equation, let me acknowledge that, yeah, if we use the individual level data, estimations take a lot of time. So a standard practice is to collapse this micro data at the cell level. So they are computationally less intense. So we estimate our models in cells, and by cells we mean cells by mother's race, age, marital status, and education. But when we have estimated our main models with the individual data, and the results are practically the same. So let's go back to the equation. Here we have the outcome of interest, let's say the birth weight for cell I, meaning all birds in this given cell that were born in county J and in GRT. So D is our binary treatment variable that is going to be equal to 1 if a county ever receive a community health center grant. And this expression here capture the event times relative year with respect to the introduction of the rollout. This is capturing this event times relative year before the introduction, so meaning -2 years before a county introduced the CHC, -3, and so on. So these event year dummies allow us to test the parallel trends assumptions, while this expression here capture the event year relative time dummies after the adoption. 0 will be at the time of the adoption of the CHC, plus 1 year after, and so on. And this will allow us to examine the dynamic effects. So we control by the standard fixed effects and demographic characteristics. So we control by gender, by the fraction of Black mothers, the average age. We also we are going to present several specifications, but our baseline specification will control for county and year fixed effects. This vector X, J, T is capturing time varying county and state characteristics that could be correlated or that can contemporaneously influence the rollout of community health centers. For example, transfers per capita. During this time, other two big war on poverty programs were introduced, food stamps and family planning. So we also control for that. And we cluster the standard errors at the county level. So now, before moving to the results, let me discuss the identification assumptions for the difference in difference framework. So the standard, one important key identification assumption is the exogeneity of program placement, meaning that the timing of the CHC rollout is exogenous after we condition on other covariates. So here we test this assumption by regressing the CHC introduction year on 1960 characteristics. So these are pre-programmed characteristics, and we are examining whether they can predict whether a county roll out the CHC early versus later on. And here we present several estimations of this test. In green, you see unweighted regressions. In blue, you see weighted regressions with no state fixed effects. And then in black, you see weighted regressions with state fixed effects. By weighted, I mean weighted by the population in the county. And here, the main takeaway is that we see that this timing of the CHC introduction seems to be correlated with a few of these pre-programmed characteristics. For example, we see here at the bottom that of doctors per capita receive community health centers early. That is expected and is actually aligned with the reports where the first counties were community health centers were urban counties. And yeah, we know that the CHC was not completely random. So yeah, finding these associations explain that this policy was quasi-experimental, quasi-random. So we also see that the introduction was correlated with the percentage of urban population in 1960, with the percent of populations that is non-white. But it is important to acknowledge, and here when you look at the R-squared, that a lot of the variation in the timing remains unexplained. So it is not that these characteristics, and we have a lot of characteristics in the regression, explain a lot of that variation. There is still a significant amount of variation in the rollout that is not systematic. So to address this assumption of exogeneity of program placement, in one of our specifications, actually in our preferred specification, we are going to include the significant 1960 determinants interacted with flexible trends. Then the second important assumption is the parallel trends assumption, meaning that the counties that adopted CHCs and those who did not would have the same trends in the absence of the program. A way to test that is by looking at the event study leads, and we will see that in the event studies, and then we also perform some placebo tests. Lastly, about the last assumption, so you all are aware that the standard practice in difference indifference is to estimate a two-way fixed effects model, meaning fixed effects by geographic and by time, by the two difference, but there is a new body of literature that have documented that this standard approach, this two-way fixed effects, is biased particularly when we have a staggered treatment adoption, like our CHC rollout. This literature have found that in order for these standard two-way fixed effects to be unbiased, we need to assume homogeneous or constant treatment effects. However, this is a very unlikely assumption and not really plausible, because it's possible that the treatment effects of community health centers and other staggered policies could vary across counties and over time. For example, meaning that the pathway of effects of community health centers in a county in California can be different to the pathways of effects of a county in Michigan. So because these homogeneous and constant treatment effects assumptions is very unlikely, we have to be cautious when we employ that methodology. This new literature has identified that two-way fixed effects is biased because basically two-way fixed effects is a weighted average of these different type of difference in difference. So two-way fixed effects is going to estimate difference in difference that compare the early treated versus the never treated to create the contrafactual, the later treated versus the never treated, the early treated versus the later treated, and then I particularly highlight this in red. It compares the later treated with the early treated as part of the comparison group, and this comparison can be as seen, is what the literature call it, because these early treated are used as contrafactor for the later, and these early, if they have heterogeneous treatment effects, they are not really a valid contrafactor. And that's why the two-way fixed effects can give us an estimate. This weighted average of this difference in difference is not the average treatment effect. So before that, before moving with our results, we first diagnose what is the degree of treatment effect heterogeneity in our setting, in the community health centers rollout. So to do that, we perform some of the diagnosis tests that have been suggested by the Chess-Martin and the Halsfolia. In their paper, they propose a test that estimate the standard two-way fixed effects regressions. They extract these weights and then they regress those weights against or using as covariates factors that could be associated with the size or intensity of the treatment effect. So basically, yeah, they get those weights and they regress those weights against several, we regress those weights against several factors. For example, here we regress those weights against GR. We could expect that the heterogeneity across time, and indeed we find a correlation that is significant. The T-stat is larger than 2, saying that there is some heterogeneity across time. We also see some potential treatment effect heterogeneity because we find strong correlations between the weights and some characteristics like hospitals per capita in the county or the share of non-white women on this welfare policy, the AFDC. So given that we have some presence of treatment effect heterogeneity, we are going to use one of the alternative methods that have been proposed, that is the Son and Abraham procedure. In the robustness checks, we estimate the two-way fixed effects. And I'm gonna very briefly say what the Son and Abraham procedure does because I wanna show the results. But basically, what Son and Abraham does is they are going to divide each observation by cohorts, meaning like observations in counties that adopted the CHC in the 1970, this is the 1970 cohort. Observations that adopted the CHCs in 1971, they are the 1971 cohort. Plus we have a never treated group, a never treated cohort. And basically what they do is a fully saturated interaction weighted estimator that interact those relative time dummies with the cohort dummies. And they based on that, they construct cohort specific average treatment effects. So here we have the first set of results for our main outcomes, that is birth weight and low birth weight. And let me explain you the setup. So we have here 3 sets of specifications, the baseline specifications that control for socio-demographic characteristics like gender, race, county, and GR. And then in green, we add these geographic, state and county time varying controls like other transfer policies and other war on poverty programs. And because Medicaid was also rolled out during those years, but that is a state policy, we control for a proxy of Medicaid in a given state. And lastly, in blue, we have a specification that is our preferred specification, that is the one that additionally control for those 1960 determinants that are significant using flexible trends. So one here, for the case of birth weight, we do see that in the pre-program period, there is not much evidence about differential trends between places with community health centers and places without community health centers. And we do see an increase in birth weight after adoption of CHC. What we see is that exposure to CHC increased birth weight between 3 and 6 grams. This is around 0.07 and 1% of the mean. It is also worth highlighting that results are not very sensitive to the specifications. Like estimates are very similar across the different specifications. Regarding low birth weight, we also do not see evidence of pre-programmed trends, and we do find a decline in the incidence of low birth weight post-CHC adoption that is around 0.4% of the mean. So these effects that I just mentioned, those are intent to treat. Those are effects on the full population, exposure to the CHC. And if we compare it to other war on poverty programs, these effects are within the ranges of those effects on birth weight and low birth weight found by food stamps and WIC programs. It's also relevant to try to think about the treatment on the treated effects, but to do that, we need to find data about participation rate of pregnant women in the community health centers. There was not really detailed and consistent admin data on pregnant women use of community health centers in the 70s and 80s, but we gathered some information from reports, and we found that around 213,000 pregnant women use community health centers in a given year by 1988. So using this number, we try to approximate a participation rate. To do that, we also take into account the total births. So in the viral statistics, we see that on average between 1968 and 1988, there are 3.3 million births per year in all counties in the US. So if we combine these two numbers, we have a participation rate of pregnant women in CHCs of 6.4%. But if we only take into account the births that occur in the counties that had a community health centers, that is a 2 million average, so the participation rate is 11%. With this participation rate, we estimate a treatment effect on the treated between 25 and 42 grams for birth weight, and between 9% and 16% for low birth weight. And again, this treatment effect on the treated are very similar to these other war on poverty. Now we look at some heterogeneity, and yeah, it's expected that low SCS mothers are the ones who experience larger effects because they are the more likely users of community health centers. So here we look at the effects by maternal education as a proxy of socioeconomic status. And we do see here in red is less than high school, in blue high school, and in green greater than high school. And we do see evidence that the impacts tend to be larger for mothers without a high school degree. So now moving towards the mechanisms, let me summarize how we're going to proceed. So back in the 60s, 70s, and 80s, the viral statistics data was not very detailed. It's not like the viral statistics now that have a lot of information. So first, in terms of mechanisms, we are going to explore other birth outcomes and prenatal care use data that was collected by the viral statistics during our periods. But then to examine other potential mechanisms, we are going to rely on other auxiliary data. So to examine maternal risky behaviors, we are going to use the NLSY, and to examine use of healthcare, we are going to use the survey of health services utilization. So first, in terms of other birth outcomes in the parallel statistics, here I present the static results, but we have the event study here. And here the main takeaway is that, yeah, we do find that exposure to community health centers also reduce the likelihood of being born with very low birth weight. Very low birth weight is defined as a weight less than 1,500 grams. There is also a decline in the incidence of small for gestational age, and gestational age is correlated with birth weight. So it's reassuring to find these effects, this decline in small for gestational age. We also see an increase in any prenatal care use, but it's important to notice that the fraction of any prenatal care is very high. So a more relevant marker is the timing of prenatal care, and particularly getting prenatal care in the first trimester is very relevant for improving health at birth. And we do see here that exposure to community health centers increase the use of prenatal care in the first trimester. So yeah, we could see the event studies, but they are aligned. So now, during the prenatal care services that were one of the main services provided by these community health centers, in these consultations, women receive counseling about healthy behaviors and nutrition. So it seems relevant to examine whether exposure to community health centers could affect the incidence of these risky behaviors that also affect birth weight. So to do that, we need to use another auxiliary data. As I was explaining, we use the National Longitudinal Survey of Youth. We use women with pregnancies by 1988. And we look at the full sample as well as a less than high school sample, because we expect the effects to be stronger for these low LCS mothers. And we find that indeed exposure to community health centers reduce the likelihood of maternal smoking, which is aligned with the evidence that reduction in maternal smoking improve birth weight. Now, lastly, an important first order effect of exposure to these community health centers is access and use of healthcare. So it's important to examine how exposure to CHCs affected women access to these services. However, back in the 60s, like before the CHCs and after, there was not really systematic data about pregnant women use of healthcare. So we examine one source of data, that is the Survey of Health Services Utilization and Expenditures, that it was collected in 1963 before the CHC and in the 1970 after the CHC. We, of course, we acknowledge that this is just going to only cover the effects of the CHCs in the initial phases. So this Survey of Health Services Utilization do not allow us to focus on pregnant women, but we can focus on a sample of women in fertile ages, meaning women ages 15 and 39, and using this repeated cross-section, we estimate a very simple difference in difference, where this survey sampled the same geographic units, and we are able to see whether a woman was in an area that had a CHC by 1970. So we interacted with the post, meaning the way in 1970, and here we do see, and particularly for the less than high school women, we do see evidence that exposure to the CHC increased the likelihood of women having regular sources of healthcare, and conditional on having this regular source of healthcare, clinics are an important source. So this gives some evidence that preconception, improvements in preconception health could also be a plausible mechanism. Now, lastly, let me try to just wrap up. So we also explore whether our effects could be explained by fertility responses to the community health centers or by changes in the compositional or in the characteristics of mothers giving birth. And we do not see much evidence of fertility responses of these compositional effects. We also did several robustness checks. Here in red, we have our preferred specification, that is the one that control for the 1960 determinants. The two-way fixed effects specifications are similar but noisier, particularly the two-way fixed effects have some pretrends. We see that also the effects are robust to adding stable year fixed effects, or if we use conception instead of year of birth as the time variation, the results are robust, and we did several other robustness. So now to conclude, in this paper, we provide new evidence about the community health centers, the program, and their improvements in birth outcomes. We see that potential mechanisms are early prenatal care use and reduction on tobacco use during pregnancy. And this evidence has important policy implications because community-based health programs are becoming really popular in developing countries as a way to reach the poor and underserved populations. So thank you so much.
Thank you, Maria, both captivating and conclusive. Policy actually works the way we would hope it would work, at least my interpretation. So let's open it up. We have a few minutes. Open it up to questions.
So I just have a question to ask Sally because I have to go teach now. So when I was looking at her results, a couple of questions I have is, in terms of the controls, do you have any information about the number of kids or the spacing between the kids at all? I mean, like for your regressions?
You mean birth spacing? Sorry that I
yes.
didn't hear.
But yeah, spacing between the children or the number of children.
Yeah, but that could, yeah. So we have parity. We have information of the number of children that a woman has. It could be endogenous if there are fertility responses. So it could be about control, but we do not see fertility responses. So if we include parity as a control, the results are going to be robust. Yeah, we have seen that.
Oh, okay. Okay, good. Thank you.
Thank you so much. Yeah, that's
yeah.
Thank you.
Okay, I have some just some technical question. You use birth weight, which I know is used mostly around the world, but in the US, I don't know how long they've been calculating this. Don't they calculate the APGAR score?
Not back in the viral statistics.
Early days of the 70s?
No, that's more after in the 90s, starting in the 90s.
Okay.
Yeah, we will love to have the APGAR score because you are right. Like, of course, birth weight is widely used globally as a measure of health at birth, but it's not perfect, but it's objective. So, but right. Yeah, there are other markers, but thank you. Yeah, that's a very relevant.
Okay. Olga, please.
Yeah, thanks a lot. Very interesting presentation. I would be interested to know whether you could also consider the some extensive margin more like abortion rates, whether there were any effects on abortion rates or unwanted pregnancies in general, especially in early age and something like that.
Yeah, good point. I don't know if we could capture unwanted pregnancies. Abortions, I don't know how is, yeah, we will need to check how is the admin data back in the...
But maybe in general, the number of births in early age? Not the general birth rates, but the births in the like pre-18, say.
we do look at teen mothers, like the births that occur to teen mothers, and we didn't see much effects on teen mothers.
Okay, thanks.
But yeah, thanks.
It's a question also, if you have these community health centers had to be put in locations with low numbers of doctors and associated staff. So that means I would not find these in cities which had major hospitals, even if there was a high poverty.
I think they're like some, like the initial health centers. I think there was one in Boston. So yeah, it could be, there could be located in a high poverty area in a city. And especially those community health centers at the beginning of the program, meaning in the late 60s and early 70s, when the program started, they were located in urban and high poverty areas. Yeah.
Okay. Interesting. Okay. Other questions, anyone? Comments? Do you have any data on survival? It's sort of getting at what Olga was saying in part. I mean, as opposed to child fertility, but on survival of infants.
Yeah, that's in our next to do is looking at infant mortality.
Okay.
So we will be looking at that in the next couple of weeks.
Okay.
Yeah, that's a good point. Yeah, yeah, we are doing that. So we will hope to include those results as well.
Okay. Okay. Other comments, questions?
Thank you so much.
Okay. Well, thank you, Maria. That was on time, and I find it convincing.
Thank you.
Next month, Sarah Perlman will be our speaker on the first Thursday of April. Klaus, do you have anything else you'd like to say?
No, thank you very much. It was a very, very impressive presentation, and we are looking forward to the next event in April. Please join us then.
This will be available in a few days, posted.
Yes, the video comes up in a few days on the GLO website. Please check there.
Okay.
Thank you so much for your comments and feedback. I really appreciate it. And I will see you next month.
Thank you. Thank you. Till next month.
Yeah, thank you. Thank you so much. Bye.